For those of you, and I see a lot of familiar faces here today from yesterday, for those of you who were here, I am very briefly going to review what I think I attempted to convince you of yesterday, and that is that an element of exercise intolerance in ME/CFS and long COVID is related to dysautonomia and the autonomic nervous system dysfunction. And at the end of this talk, I'm going to attempt to link some of the notions about dysautonomia and dyspnea. So this is shortness of breath on exercise in ME/CFS and long COVID. This is a woefully understudied area. Dyspnea is a complex symptom. It has many facets. When I was a fellow back in the day, and this is a long time ago, Dr. Plasma, long time ago, I went to a symposium on dyspnea at the University of Pennsylvania, and they showed a clip of one of the greats in ventilatory control, it was Julius Comro. And he addressed a conference again at the University of Pennsylvania where he was. They showed a film of this. He said, we're going to get together over 3 days and talk about dyspnea. And at the end of the 3 days, we're not going to have any idea what we're talking about. So it's a complex symptom with a lot of facets. But I'm going to attempt to give you, at the end of the day, a little hypothesis here, a little hypothesis generating data. So yesterday, for those in the remote audience who may not have been here, at the Brigham and Women's Hospital and Yale and Porto and Sao Paulo, we are doing invasive cardiopulmonary exercise testing, which gives us a very deep dive into the pathophysiology of exertional intolerance in ME and long COVID. And I'm not going to show the movie again, but just to recap, we've got a metabolic cart that measures pulmonary gas exchange and ventilation. We've got 2 catheters, the radial and pulmonary artery catheters, which give us blood flow measurements, amongst other things. But we also we're very carefully measuring all things related to ventilation and therefore indirectly related to the sensation of shortness of breath or dyspnea. We will keep going. So what I attempted to convince you of yesterday was that most patients with ME and long COVID who are free of heart and lung disease, super important in long COVID, end up in these 2 buckets in our diagnostic flow diagram. They have mildly depressed peak exercise VO2s, and the reason for that is a combination of preload failure. This is failure to prime the pump, failure to adequately move venous blood against gravity in the upright position up to the right heart, and additionally a problem over on the arterial side, which is manifested with our testing by impaired systemic oxygen extraction, and we think one of the reasons for this could be peripheral left to right shunting, in turn a form of dysautonomia. So we think that both of these things potentially are related to dysautonomia or autonomic nervous system dysfunction because of the Philip Joseph paper that I presented to you yesterday that suggested a very high prevalence of something called small fiber neuropathy. So the small fiber nerves play a role in blood vessel tone and blood flow. So this is a recap of what I attempted to tell you yesterday. What I'm going to try to tell you today is that this very same entity, neurovascular dysfunction, and in particular the autonomic nervous system dysautonomia, may play a role in shortness of breath. So I'm going to flash back to the Will Oldham paper, and buried in the title was the fact that what we were initially trying to elicit reasons for was unexplained exertional shortness of breath or dyspnea. And what we ended up finding was that all these patients sent to us with unexplained dyspnea had ME/CFS. This was in the pre-COVID era. Now, others have jumped on board after our initial findings, including here the Cleveland Clinic, where they've also related the sensation of shortness of breath to this preload failure. This is the low filling pressures in the upright position that is the hallmark of ME/CFS with our type of testing. Now, how does shortness of breath develop? Here's a little cartoon that kind of simplifies I think, the conventional wisdom about why one becomes shortness of breath. It's an imbalance between ventilatory demand, and I'll get heavily into this, and ventilatory capacity. So the demand to breathe versus the ability to generate airflow with a ventilatory pump. And when there's an imbalance, excessive demand related to capacity, dyspnea or breathlessness ensues. So this is a basic concept in exercise physiology. If ventilatory demand exceeds capacity, shortness of breath will ensue. Now, there's a lot of different pathways that have been studied over the years in terms of ventilatory demand. And there are a variety of neural and humoral signals that are depicted here. We'll summarize first. There are afferent pathways to the brainstem that then travel northward to the higher cortical areas where shortness of breath is sensed by the brain. But they're all mediated largely by the vagal nerve. And they come from the lung. When the lung is dysfunctional, there's some of this. They come from the heart, both the left and the right heart. When the heart is dysfunctional in any way, shortness of breath can ensue. They come from chest wall receptors. And as you'll see, I'm going to focus on this. They come from the exercising muscle as well. And there are a couple of varieties of pathways related to exercise, meaning increased metabolism from the muscle, that are at play that drive ventilation. One is a humoral pathway, and the other is a neural pathway, and I'll come back to that. Now, our best insight so far into the mechanisms for shortness of breath and long COVID come from Indy Singh's paper of long COVID, which I presented an element of yesterday. What I told you yesterday is that it looks frighteningly like ME-CFS. So preload failure and evidence of impaired oxygen extraction. What Indy also did was a deeper dive into the mechanisms for shortness of breath during exercise in long COVID. And I'll walk you through a little basic pulmonary physiology here. What Indy found was evidence of ventilatory inefficiency in patients with long COVID compared to normal controls during upright incremental cycling exercise. And this is one way to measure it. It's a really conventional way to look at ventilatory demand and ventilatory control during exercise. It's called the VE-VCO2 slope. Basically, this is the amount of minute ventilation, the bulk flow of air, divided by the unit of CO2 excreted. So how much ventilation is required to get rid of how much carbon dioxide? And we have a slope that's measured during incremental exercise. Abnormal is elevated. The patients with long COVID that I presented yesterday from the Singh paper have elevated VE-VCO2. Physiologically, there are two reasons for elevated VE-VCO2 slope. One is, and this is the alveolar ventilation equation, one is hyperventilation. So if one hyperventilates and drives the carbon dioxide level down in arterial blood too low for what the body needs, one will have elevated VE-VCO2, a non-invasive variable. The second one is physiologic dead space to tidal volume ratio, which I won't get into heavily here, but this is a marker of parenchymal lung disease. So if you have a long COVID patient who has fibrotic lung disease because they had ARDS and they ended up on a ventilator, or if they have pre-existing disease, which Drs. Singh and Joseph have written about, like heart failure, they will have a problem with physiologic dead space to tidal volume ratio. This should fall normally during exercise. And to cut to the chase here, in long COVID, it falls normally in patients free of heart and lung disease. What patients free of heart and lung disease do, though, during incremental exercise with long COVID is hyperventilate. So these PaCO2s, the arterial PCO2 is too low at peak exercise and the arterial pH is too high. These are direct measurements of hyperventilation. So what we conclude here is that with a limited number of patients so far, we're doing further studies on this, that dyspnea and ventilatory efficiency, which are very much intimately related, are related to hyperventilation, too much breathing for what the body needs, getting rid of too much carbon dioxide, relative alkalemia of the blood, not due to parenchymal lung disease and ventilation perfusion mismatch. So others, this is a nice European study that got on board with this notion that in long COVID, hyperventilation is one of, it's in our view, the mechanism of persistent shortness of breath after COVID in patients free of heart and lung disease. All right, so we will ask the question here, and this is getting into the realm of hypothesis generation. What drives hyperventilation if it isn't heart or lung disease? So if we can cross out with invasive CPET, dysfunction of the lungs, which we've just done and I've shown you, and dysfunction of the heart, what are we left with that could drive this hyperventilation? What pathways are relevant? And I think the answers are the chemoreceptors, and there are two varieties. One is the classic chemoreceptor. This is the ventrolateral medulla. It's sensitive to carbon dioxide. The other are the carotid bodies that are sensitive more to hypoxia or hypoxemia in the blood. The other, and this is a relatively novel pathway, and I want to leave you with the thought that this may be very relevant to both ME and long COVID, are metaboreceptors in the muscle. So these have been known to exist forever. They're unmyelinated small fibers. They're the very same small fibers that we've shown to be dysfunctional and deficient in the Philip Joseph paper in ME-CFS. I would point out the ones that remain, so they're usually small fiber neuropathy is diagnosed by a deficiency of small fiber density in the skin. But the ones that remain are often overactive and dysfunctional. Read fibromyalgia. Nice example of that. So a theory is that these small fiber nerves that terminate in the interstitial fluid of muscle, they're known to regulate normally exercise, ventilatory control, blood pressure, and cardiac output. A hypothesis here is that they're dysfunctional and they may drive excessive ventilation as well. So this is the skeletal muscle metaboreflex that emanates from the muscle, goes up to the brainstem, and drives ventilation and cardiovascular function. I'll quickly just allude to this paper by a real authority in the field of dysautonomia, Dr. Raj from Canada, who has looked at a very much related disorder, which is POTS, postural orthostatic tachycardia syndrome. Everybody in the room probably knows about the overlap between that and ME and long COVID, and there is substantial overlap. And what he did in this elegant study was shut down the peripheral chemoreceptors in the carotid body by giving human beings hyperoxia. So if you give lots of oxygen inspired, you can shut down the carotid bodies. And he showed that the upright tilt table test, which elicits hyperventilation, and in our research, we see the very same thing in patients who've had both tilt table test and the invasive CPET. We see hyperventilation in both. He's shown that the hyperventilation persists after shutting down the carotid bodies. So I think this moves the focus of the genesis of hyperventilation to the periphery and perhaps to that skeletal muscle metaboreflex and perhaps to the very same small fiber neuropathy that we talked about yesterday. I'm going to give you a quick flashback to an ancient study of mine, and I've been teased by the youngsters in my lab that this is not even really available through AI. We've got to go back and find this paper from 1998. We did very quickly a study in normal individuals that documented this skeletal muscle chemoreflex is relevant to ventilatory control. This is in normal individuals. And we did so by taking normal individuals, putting them in a phosphorus MR spectroscopy magnet where we can measure muscle metabolism directly and pH in the muscle. And we did a very simple intervention, which is done by others, big blood pressure cuffs around the proximal thighs during exercise. You inflate them, you trap metabolites in the lower extremities, you stimulate the neural reflex because none of the metabolites is getting centrally to the arterial or ventrolateral medulla chemoreceptors. You deflate them, and then you have the humeral reflex. So what we found there was during inflation, we had hyperventilation. That's this curve here. And that inflated cuff was associated with a more acid muscle pH. This is muscle, not blood, by phosphorus MR spectroscopy. And when we tried to link that minute ventilation during low-level 3 minutes constant load exercise, there was a regression. The more acid the muscle, not the blood, the more ventilation. So we think this is the skeletal muscle chemoreflex in normals. We're postulating this is on overdrive in ME/CFS and long COVID, mediated through dysfunctional small fiber nerves. So this is a diagram that suggests that in patients with ME and with long COVID, free of heart disease, left or right, who have this peripheral limitation that we think is mediated by small fiber neuropathy, we think we may have a neural reflex that is driving ventilation and creating dyspnea. So we are going to further study this with a so-called LIFT study, and a special call out to Linda Tannenbaum, whom you just heard, who has helped fund this study that we're just beginning at the Brigham in Boston, with the help of Jonas Bergquist, who's here in the audience from Uppsala. We are going to do the following study, and this is designed to both look at treatments of ME/CFS in this case, and hopefully ultimately long COVID, but also better understand the disease. So we have two drugs that we've used in the clinic at the Brigham frequently. One is low-dose naltrexone. It's thought to be anti-inflammatory. High doses, it's used in addiction medicine. Low doses, it tamps down the toll-like receptors and decreases inflammation. Inflammation is bad for nerves. Inflammation may beget small fiber neuropathy. So this is one intervention, low-dose naltrexone, designed to interrupt that pathogenic pathway. The second one is pyridostigmine or mestinon. It's FDA approved for myasthenia gravis. We think it facilitates nerve traffic that's dysfunctional in small fiber neuropathy. But because it's cholinergic or parasympathetic, over time it may also be anti-inflammatory and favorably affect the small fiber neuropathy. So we're going to ask a lot of questions with this interventional trial. These drugs are used in combination or in isolation compared to placebo. There'll be 40 patients in each group, studied over 3 months with a variety of outcomes. There are well-validated questionnaires, one of which you heard from Linda Tannenbaum, the FunCap from Norway. We have another measure of brain fog, and then another measure of post-exertional malaise. Patients will receive these questionnaires, and our computational group with Wenzong will be analyzing these. We have a variety of blood and urine biomarkers, metabolomics, transcriptomics, proteomics, and peripheral blood mononuclear cells being studied at Cornell. All of our patients are going to have a wearable device. This is the most modern Garmin variety, which you can see, amongst other things, measures things related to ventilation. So that's oxygenation and respiratory rate, but a variety of other cardiopulmonary markers as well. They'll be wearing this over time. And then finally, we're going to do a non-invasive exercise test, which is called the SHAPE study. I alluded to it briefly yesterday. This is it. It's a 3-minute constant load test with a metabolic cart. It gives us all the non-invasive variables that an invasive CPET would give us, and a couple of measures that correlate pretty well with VO2 max and related numbers. Most patients do quite well, even those with orthostatic intolerance. There's something to hold on to. It's self-paced, and patients do not realize crashes afterwards. So this is what I wanted to leave you with today in terms of dyspnea and its relevance to ME and long COVID. In patients free of heart and lung disease, it appears that exercise hyperventilation is the underlying pathophysiology. It's not parenchymal lung disease, it's not heart disease, it's hyperventilation whose genesis is poorly understood. And we think based on the Raj data that I just presented in POTS and upright tilt table tests, perhaps the arterial chemoreceptors are not the full explanation, and this includes our own data with the muscle metaboreflex. So we're proposing today and moving forward that there may be a role for these group 4 small unmyelinated fibers that are known to be dysfunctional and cause blood flow abnormalities on the one hand, but may additionally put the ventilatory response to exercise on overdrive and elicit dyspnea. So the LIFT study, courtesy of OMF, will help explore all the pathophysiology underlying hyperventilation, but parenthetically, additionally, and importantly, fatigue, post-exertional malaise, and orthostatic intolerance. And we think this is a really nice paradigm for doing studies in this area, because it will allow us, yes, to answer the question, do the drugs work? But if the drugs work, we can go backwards and learn more about the disease itself and then further refine treatment moving forward. So thank you very much for your attention.